Welcome to another episode of Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist working in southern Vermont.
My name is Robert Stack. I'm a licensed alcohol and drug counselor and a licensed mental health counselor. Good evening. Before, we were going to do some questions that we've gotten from previous programs, but before we do that, I want to, yesterday in the New York Times Sunday section and also in Today, they had some front page articles about buprenorphine, which is a medication. I almost hesitate if I say it's a drug or is it a medication. Anyway, it's something that is used to treat opiate dependency. And the article is extremely well done, and both today and yesterday, very lengthy, and they went, I think, great lengths to sort of be fair about it. But I think if anybody at all is interested in the current treatment of opiate addiction, specifically around Suboxone and buprenorphine, I mean, I think this is something that needs to be talked about. So, with your indulgence, studio audience, everybody, I like to talk about it. I'd like to have some discussion about it and tell you some of our reactions.
Yeah, because it's funny. I mean, when you saw this right away, you called me up and told me, hey, there's this article in the New York Times, and we were a little put off by it, aggravated by it. I got an email from a colleague of mine that said, have you seen this article? It's in the New York Times, and it looks really interesting. So from her perspective, probably seemed more balanced, whereas from our perspective, I think we probably read between the lines. But it really brought up some I don't want to say accusations, but some of the difficulties that we struggle with what we think is a valid treatment and with what other folks often term to be a drug for a drug.
Right, and that's exactly it, I think, on some level. I'm an old school counselor. I've been counseling for close to 30 years. And, the model's always been abstinence. And, Vermont was really late to having methadone treatment. We didn't have methadone treatment, but we didn't have that many opiate addicts, quite frankly. I mean, I worked on a unit at the hospital, and we would see some. But mostly it was maybe health professionals. There wasn't a lot of street addicts, opiate addicts. Right. But that's not true anymore. And we've had a tremendous explosion of opiate-dependent young folks coming in. And, the relapse rate statistically is so high when you detox somebody off opiates. And if you don't have some follow-up for them, some support system, there was a high relapse rate. I mean, so it was really difficult. Like you said, Governor Douglas sort of signed and we were able to have methadone in the state. And so that was a real breakthrough for us to offer methadone maintenance. But the numbers of people who were suffering from opiate addiction was growing. I mean, almost on a, what's that mathematical thing when they're doubling?
Oh, yeah, arithmetic, geometric progression.
Yeah, it was really fast. I mean,
exponential.
People were they're skipping marijuana, they're skipping booze, and they were going right into opiate addiction, and again, the choices and opportunities for treatment were few and far between. Even the methadone slots were numbered, if I remember correctly. If that's
until about 2 years ago, there was a limit to how many patients that Vermont Medicaid, for example, would actually pay for their care with methadone.
And how many places were in the state that actually offered methadone?
I mean, originally when Governor Douglas started this, we had the Chittenden Center up in Burlington, and then slowly other companies have brought in other methadone clinics, and we have, I think, 5 right now.
Right. And the methadone clinics, you had to go there every day, right, and get your dose.
Right.
And it was sort of regulated and very strictly regulated.
Oh, yeah, absolutely.
But one of the reasons why some people like Suboxone is that you can take it home. It's a prescription, and it's something that you can come and not have to go to the clinic every day. And one of the reasons that I found that we liked it was that it was very hard to overdose on it. It had like a maximum effect. Now, it still had an opiate effect, but it sort of, we believe, it sort of peaks out at a certain level. And unless you mix it with some other drug, like a benzodiazepine, there's less risk for overdose.
Right.
That's not to say it doesn't happen.
Right. It still happens.
It still happens, especially to naive opiate users who use too much Suboxone early on, thinking that it's totally safe.
Well, there's a suspicion, too, that maybe some younger users are coming to opiate dependency through Suboxone, through the buprenorphine, because it's actually a milder opioid. And so, therefore, younger people are trying with less stigma and less risk.
Right. And I remember working with clients, and they'd come in and they were opiate dependent, and they were looking for a Suboxone provider. And for a while there, we had a lot of Suboxone providers, but we also had very restrictive providers that didn't want to take new clients, or they had reached their limit. They had reached how many they want. So I remember seeing at one point that per capita, Vermont had more Suboxone providers per capita.
We've always been at the forefront of this.
Right. But on the other hand, if you've ever worked in a hospital with opiate addicts, it felt like we could never find one.
Oh, yeah.
I mean, it was really, really difficult. Like in the Rutland area or Burlington area, there were waiting lists. There was Montpelier, anywhere in the state. You know, you and I both seen that wonderful film about the doctor who...
right, Hungry Heart with Dr. Rogers up in...
Rogers?
I'm sorry.
No.
No.
Anyway, so but no, he did. He provided, and he was coming at it from pediatrics.
Fred Holmes.
That's right.
Yeah.
But he was coming at, you know, that he had treated these as kids, as you know, in a pediatric service. So anyway, so to get back to these two articles, the thing is that for some people, and it sounds like a wisecrack, but for one person said. You sure we're not just moving somebody from who drinks Budweiser to Bud Light?
Right.
Because we are providing an opiate to clients. But I have to tell you that, you know, I've really struggled with it. I mean, my biggest concern, I think, is that it's almost as if, like, if you give me this drug, and this is the good part of it, if you give me this drug, I can have a normal life.
Right.
I can go to work, I can, you know, go to school, I can be a good parent, I can be more, but on the same token, I think for some people, there's still, it's just another drug. And we've noticed that, you know, like any treatment, some people will take it as medicine and do the right thing with it. But for other people, it's just another drug.
Well, it's such a difficult illness, right? I mean, you talk about with methadone clinics, when they first came on the scene, there were all these sort of overtones of abstinence and still not really seeing opiate dependence as an illness or a disease. And then along comes Suboxone. We start to move it out to primary care doctors to be able to treat their own opiate-dependent patients with this sort of naive idea that, okay, now we're going to get this under control. We've got a safer treatment. It can be more widespread. There's not the stigma that's entailed with everybody comes to the clinic, gets their dose there, and lines up every day. And I think we've found, and what really this article was pointing out, I mean, the title of the first one talked about the dark side of treatment. Today's article, what they talk about, turbulent lives, tumultuous treatment, turbulent lives, which maybe speaks to what we've noticed is that, oh my goodness, there's no easy way to do this. Just prescribing medication is not enough, because my impression is that a lot of family doctors or primary care physicians who have gotten out of prescribing Suboxone have done this because they've realized the complexity and difficulty of working with this population. And it seemed like this article kind of showed that sort of murkiness and the back and forth and the tug and push and pull that comes with working with people with addiction. But it felt like this sort of moral tinge that addicts have. You know, why don't you stop, self-control, morals, that sort of thing. It seemed like they were sort of painting the providers with the same brush there.
Yeah.
Right? They talked about how more providers have been, more of the doctors have been sanctioned or lost their licenses than maybe the percentage of doctors in the general population of doctors. And some of one of the physicians they portrayed there was not your image of your, white coat and tie physician.
Right. And you know, a couple of weeks ago, I had the honor to go up to a bunch of doctors who work in the field of addiction, and got an opportunity to go up and speak with them about spirituality, and it was a great honor for me. And the people in the room were just amazing. And I don't think you could say which one was in recovery and which one was just a doctor who was working with people who had addictions, or, I mean, these are just wonderful, beautiful people, and people who have dedicated their lives, and I include you in this. No, I mean that. I mean, people who are, who are willing to help, willing to work with addicts and alcoholics. I mean, who are willing to sort of say, and whether they do it because they struggled in their own life or in their families or whatever reason. I mean, sometimes you just say, like, listen, I want to help these folks. And I thought, I want to encourage people who are interested in these topics to read the article, go there, and, you know.
Right. I mean, NYT.com. It's as easy as that to get to the New York Times, and until you do like 4 or 5 hits, you can see a free article most days.
And I would really recommend, and I think at some level, and it's always a strange thing to see, that reporters often want to show both sides of it. You know what I mean? Like to do a fair job and not just show one side or the other. And in a way, I think the article did a really good job of that, because I just was all over the place.
Right. Good job, bad job.
Yeah,
right. You
good.
just
Oh, I like
settled
this,
on
or I
that,
didn't like this, or, you know, this is fair, that's not fair. And, you know, a lot of it had to do with my perspective.
Yeah.
And so, you know, I'm because the name of the show is Let's Talk. Let's talk about addiction. Let's talk about mental health.
Yeah.
I really would love it if people who are interested in this topic or have comments. And it's sort of interesting that, you know, on this show sometimes we get questions from other people who work in the field, which I really like.
Yeah.
We always wonder, are we talking to people who are struggling with addiction? Are we talking to family members?
Who is out there?
Or are we talking about therapists? But I really would. If people have comments or anything about this article, I would love to hear it from them, because it is complex.
Yeah.
You know, when I first started working with dual disorder clients, I used to hear this all the time. A drug is a drug is a drug, right?
Right.
And I would say, no, that's not true. I mean, there are drugs that are medicine. I mean, insulin, penicillin is a drug. That doesn't mean it's heroin. I mean, you know what I mean?
Yeah.
Like that's an oversimplification.
Right. Well, people try to make a difference between a drug, meaning, you know, heroin or marijuana or alcohol, versus a medication, meaning something that's prescribed. But that's kind of a fuzzy line, because there are a lot of medications that are prescribed that if you stop them suddenly, you know, we call it a discontinuation syndrome, but it's withdrawal. Right. So it's an issue that's a little bit broader than that.
And I think you have to too. I mean, we'll maybe close up on this, but I just want to say that, you know, you have a wide range of clients, and you have a wide range of opiate addicts, and some of them have co-occurring disorders. Some of them have started early on. There's lots of stuff going on. And so some people benefit from methadone. Some people benefit from Suboxone. Some people benefit from Narcotics Anonymous. Yeah. Some people do better in AA. I mean, you know, some people do better in other areas. And so it's sort of, I don't want to say it's a hit or miss, I mean, but it's just like any other illness. I mean, sometimes you have to try different interventions for different folks at different times.
Yeah, and if you had, you know, early onset of diabetes, a type 2 diabetes, or were struggling with high blood pressure, and you could engage in some more healthy behaviors to minimize or make those problems disappear, and you didn't do that, you're not going to really get the same level of criticism or stigma, because you're on a medication for the rest of your life to deal with, you know, high glucose or high blood pressure numbers. Right. So I don't think people have come around, or also are not accepting the idea that addiction really does meet the characteristics of being a disease or an illness, being that it's progressive and that it can be terminal.
Right. And I remember years ago, I went to a conference down in Rhode Island, and there was a, you know, I mean, it was CEUs. It was something I had to do, but it was the New England conference, and we had someone from the feds come and talk to us about Suboxone. Now, it wasn't approved yet. But when people start questioning the wisdom of introducing another drug into the community, whatever it is, he said, what we're trying to do now is that our treatment only reaches, and this is both alcoholics, but this is true of opiate addicts, a very small segment of that population. Yeah. And so what we're trying to do is to get more people into the system. And one way that we get them into the system is through Suboxone. Right. The question is, what do you do when you get them there? Right. You know, do you get them counseling? Do you get them housing? You know, what else can you do so that life without drugs, or a better quality of life, is possible?
Right. Yes. Yeah. I'm looking at these medications. I mean, Suboxone and methadone. They're just a hook that are bringing people into treatment, and this is the point where I almost have them captive. I've got that carrot that really helps a lot. And then you're able to deal with other problems, possibly homelessness, disrupted families, single parenthood,
Dual
legal
disorders,
issues,
other
dual
stuff going
disorders,
on.
right.
And you know and I know that you were sharing this before earlier, sometimes when you first work with opiate addicts, when they come in, they feel trapped, they feel hopeless.
Yeah.
And yet, with the right intervention, sometimes the one thing you can give is the possibility that life can be different for them.
Yeah. No, absolutely. And my wife's been working with me in private practice. This was her first exposure to opiate addicts as a group. And so often people come in, they look a wreck. They've been actively using, they're possibly homeless, but their physical condition is deteriorated. And then you get them on a medication, you get them off the streets, they're stopping all the hustling and dealing, and they start to pull out of it. And you'll notice after as short a time as a month, you've got a whole new person who walks in there with you.
Right.
They're more agreeable, they're happier, they're ready to get involved in work. And we wouldn't be able to do that in a easy or reasonable fashion if it wasn't for these medications.
Right. And these medications not only help the individual, but they also help society.
Right.
I mean, it's pretty clear that methadone, for one, they said it reduces crime.
Right. Crime, medical costs, increased productivity, absolutely.
Emergency room visits,
it's a
HIV transmission. I mean, all these
Yeah.
things are benefits. And I think that, I haven't seen the statistics on Suboxone, but I suspect that that's also true.
It's got to be close
And
to it.
that it's a benefit to society. And so you run into this thing where, yes, it is a hazard, yes, it gets diverted, yes, it is an introduction opiate drug.
Yeah.
It's a major concern, something we work at, but you also have to look at it that it's a benefit for the individual, it's a benefit for society altogether.
Yeah.
And so, do things have to be worked out? Yes. Is there other things that we need to consider? Yes. Anyway, I just wanted to mention this, and I hope that if there's anybody has any interest at all in the treatment of opiate addicts, this is just one aspect of it. It's buprenorphine, but I do think it's something that's worth people looking at.
Yeah, it is. And
Okay.
there are many ways to do this, and it's not really up to us to define how people approach their recovery,
Right.
but to give them the opportunities to pick a pathway to health that they can travel.
Right.
Yeah, so we promised to answer some questions
Right.
last week, so maybe we should do just that, because we have gotten a few. And the first one, we should probably, there were a few questions that were along a similar vein. And so with this one, this is a combination of meshing together a few of the questions that we had. So is there a spirituality-centered psychotherapy which is proven effective in treating addiction or any other disorder such as PTSD?
Well, it's worth saying that when we consolidated these questions, one of the things they said that always drives me crazy, except AA. No, because a lot of people feel that way. Like AA, oh yeah, that's spiritual. But like, if I don't want to go to AA, what else is there available?
Right.
And I think the closest I can think of is sometimes, and I don't know enough about it, quite frankly, is I hear people talk about being a Zen therapist.
Right.
And they're involved with Zen and practicing what they call mindfulness meditation. And yes, there are things like that.
I mean, Buddhism has really taken hold as an alternative faith alternative practice in the U.S. now. And I hear about mindfulness and everything, mindfulness-based recovery, mindfulness-based stress reduction. So this idea of sort of meditation or being present in the moment has really taken hold and infused itself into probably every treatment we have out there. I can't tell you how many. I have probably this many books of mindfulness and various permutations on my bookshelf, and it's a regular industry.
It's funny though that this question came after we did our PTSD. We did one group a couple of weeks ago on spirituality.
Right.
Then we did one on PTSD. Yeah. So this is a viewer that put those two together.
Put those together, yeah.
Actually, if I can, and not to avoid this, but I've seen people who suffer from PTSD have a real hard time accepting spirituality, and especially if they think spirituality and religion is the same.
Right.
I know in AA they have this step where they talk about people turning their will and their life over to the care of God as they understand Him. And a lot of, I worked on a women's unit who were traumatized, And it was very hard for them to accept that there was such a thing as the care of God.
Yeah, yeah.
And they really felt like, well, where was this care when I needed
right.
it? And they really struggle with that.
That's a big dilemma too, I think, for faith in general, because the idea that is God all-knowing and all-caring, and if bad things happen to me, one of those can't be true.
Right.
Right. And so I think that sense of a loss of faith is really very common with trauma.
But I also know that, and I've seen it, is that people do benefit from the fellowship. I know that they do benefit from being with others and feeling safe with others. And meditation, I've sort of witnessed it, that it does help. It does help people. Now, I can remember when, at one point, there was some concern that some people, when they meditate, that they might experience some issues around their trauma, and it felt unsafe for them, especially when people got into guided imagery and close your eyes and stuff. And I remember hearing people being instructed by a psychiatrist, maybe they don't need to close their eyes. Maybe, be careful with guided imagery, because your imagery you think is safe may not be safe for another.
Right, right.
So
And same thing with yoga as well. Certain positions are not helpful, while yoga as a practice can actually be very useful in sort of the mind-body connection that's necessary for
So I
treating
think, as we said, I mean, obviously we looked at these questions, but one of the things that you always have to be aware of is that, what is the spirituality or the thought of the client, and you want to work with the patient where they are, the client where they are. What is the therapist's thoughts about it? Is it something they like to use in their practice? Are they comfortable talking about it? Now, we're all supposed to ask about it as part of the interview when you do an assessment. But where do you go from there? And how do you, work it into your practice, and how does the patient utilize it? And I think that's on an individual basis, quite frankly.
Right.
I mean,
Well, there's so many things to choose from. And I mean, maybe we shouldn't neglect mentioning, too, that there are certain faith-based therapies. There are Christian therapists out there, and there's Jewish therapists as well. So this is another route if you want to talk about, religion and spirituality being different sides of the same coin. Let's not forget that there are therapies that are based specifically in a religious faith.
And I think it just takes a little bit. I mean, that's why we have to be careful on the show that we don't say, well, here's how you do it, or here's who you go see. I think on each case it's sort of individual, and you have to go out there in the community and ask. You have to talk to people, find out what's available. What's your thoughts about it? Do you think it's a path for you?
Yeah.
Should
we go out on a limb and be so bold to say that if somebody tells you this is the way to do it, that you might want to take a step back and reconsider?
That's right. I would rather be the other way around. I want to explore this. I've tried meds, I've tried this, and I want to explore this.
Right.
Anyway, so I think it's a tricky question, but not tricky, but
tough to do justice to it.
Right. Okay. All right.
Okay. So now another question. I've seen people who are successfully recovering from an addiction go to another form of addiction, maybe less harmful or disruptive to their lives, but still an addiction. Right. That's as we were looking at this earlier, we're sensing kind of a misuse of the word addiction, possibly, but something that seems to describe what's seen as a sort of a trait of some people who struggle with addiction, right? Maybe almost sort of type A personality, or people call it an addictive personality, right?
Right. And it makes me, because I used to struggle with this sometimes, that people would say, well, AA is just a substitute for your alcohol, and you have to go all the time, and blah, blah, blah. And some of the criteria for addiction is that it has to be harmful.
Right. I mean, I also say, go to AA all the time, good for you. Going to church every Sunday works for you, good for you.
That's right. You go to the gym and work out, good for you. Now, if you get to a point where you're starving, you're anorexic, and you're not eating, and you're going to the gym, and you're burning up calories that you don't have,
and we got a problem.
Then we got a problem.
That's
exactly right. And I think there's also this idea that, and I'm going to repeat myself, that people use the word addictive, and I don't know if they realize. I mean, we're talking about a life-threatening illness.
Right.
I mean, so people say, well, I'm addicted to chocolate. And it's like, oh, please,
Go to a party, right? What do you do? Well, I work with addiction. Oh, yeah, I've had an addiction. I exercise too much. I love chocolate. I'm like, You know,
Yeah.
you don't get it. You're making light of something very seriously, or misapplying this word.
Right. And the only time I would like to follow up on that question is that, yes, it is true for some people that they do trade drugs.
Right.
And they will go from one drug to another drug. And I know you and I were already just before talking about Suboxone and everything else for street drugs.
Yeah.
And so if somebody wants to make that criticism, well, we can have that discussion. But most of the time, when I hear it, it's usually that someone is trading a very destructive behavior for a less destructive, like that person
Okay,
said.
sure.
I would not consider that addiction. I
No,
mean, I really
no.
wouldn't. I wouldn't. I mean, until it gets to a point where it's either self-harming or so disruptive to
Yeah.
family life or something, you know. Anyway.
No, agreed. I mean, exercising or going to weekly meetings, there's nothing addictive about that. It makes me wonder where that sort of criticism is, what that's based in.
I think it's sometimes a defense against doing what people say. Like the doctor says to me, Robert, you need to exercise. And I go, well, gee, you know, that could become addictive, you know.
Yeah.
I don't know. I don't know
Yeah.
if that's a good idea.
Take that chance, man. Take
Let's
that
do the
chance.
last one.
All right. One more question. So do women respond to alcohol and recovery the same way men do? Okay. I think we're going to maybe meld this one a little bit.
Oh, yeah.
Yeah.
Well, I think, first of all, women enjoy alcohol just as much as men do.
Right. Right. Yeah.
If that's what they're asking.
I think so. And if we look at, I mean, and one thing we should probably say, I mean, a more sort of straightforward to the point answer is that with alcohol in particular, women are more vulnerable.
Right.
If you look at the length of time one drinks before irreversible damage occurs, the amount of drinking that occurs before irreversible damage occurs from alcohol, it's a lesser amount and a shorter time with women than it is with men. So that's clear. And I think we could borrow from what happened with tobacco and cancer. Women's rates of cancer were far below those of men. Because up until about, I think maybe it was the 40s or so, World War II, women did not smoke. It was not socially acceptable. And then with women going to work, the whole image of, you know, Rosie the Riveter, then smoking became more acceptable for women. And then you saw over time, about 20, 30 years, which is about the time, how much time it takes to smoke and develop cancer on average, then you saw the women's rates of lung cancer beginning to parallel and equal those of men.
Right.
So I think with alcohol, we're probably seeing the same thing. It's become more acceptable, maybe with women's liberation and then that time there. In the 60s or so, the women are then drinking more, it's more acceptable, and we're starting to see the rates of problems and alcoholism with women be equal to that of men.
Right, and I, you know, I made a fast joke about them enjoying it. It is a special issue, and it's something that we could address maybe next year. That there are some issues around women. There's issues around women. Sometimes it's the stigma.
Mm-hmm.
You know, how do you think about a man who drinks every day? What do you think about a woman who drinks every day? What do you think about, you know, what's acceptable levels? What do you think about a man who does drugs, or what do you think about a woman that does drugs? And how do they get treated in treatment? How do they get treated in court? A lot of times there's an awful lot of shame involved. And one of the things that you have to do in order to get better is to reach out and ask for help.
Right.
I think you know, for women, it's a terrible thing to admit to.
Right.
It's a very difficult thing.
And then if you throw in pregnancy, for example, then it becomes a very loaded issue. I mean,
Right.
working with opiate-dependent women in pregnancy, just the issues that come up with that and the way that they are viewed is really awful. And it keeps a lot of women from treatment and continues to have them feeling really discouraged.
And there's other issues that have been talked about women in AA meetings and, you know, women in different settings. And I think it is valid. I mean, we ought to consider talking a little bit about the issues concerning women in recovery. But it's just like, they're just like men. I mean, they get in trouble and then they have other issues.
Yeah. And like other things, sometimes groups or treatment focused solely on women or solely on men could be helpful. And we should probably mention next week. Well, next week we're going to be off for Thanksgiving, and so I hope everybody enjoys their feast. And the week after that, Ryan Chafin from the Pathways to Housing program is going to join us. I work with them as a psychiatrist, and it's based on the issue without housing, any other sort of mental health treatment doesn't stand much of a chance of being effective. So looking forward to have Ryan on the show in a couple of weeks.
And I just want to wish everybody a happy Thanksgiving, and I hope you have a good holiday.